Good morning, good afternoon, good evening, good night, my friends from all over the world. It's indeed a pleasure and honor for me to be here and to invite our esteemed guest speaker for today, none other than Dr. Ken Serota from all the way to Canada. Welcome to this webinar session, sir.
Good afternoon, good morning, good evening, or good night. I'm not sure what we're supposed to be doing. That's okay. So how are you?
Well,
How's everything in Delaware?
I'm good, sir. I'm good, sir. And thank you so much, sir, for joining in this webinar session. And it's
Thank
indeed
you.
a pleasure and honor for us to have you with us on this webinar. And as we all know, the topic for today's webinar is dynamic navigation,
Yes.
the next generation dentistry. Let's take it that way. But before we go ahead with this presentation of Dr. Ken, I would like to share his few credentials with you all. Dr. Ken Serota is graduated from the University of Toronto Faculty of Dentistry in the 1973 and was awarded the George W. Switzer Memorial Key of Excellence in Prosthodontics. He received his certificate in endodontics and the Master of Medical Science degree in the nuclear medicine from the Harvard Fawcett Dental Center in Boston. In 1981, he was the recipient of the American Association of Endodontics Memorial Research Award for his work in the nuclear medicine screening procedures related to dental pathology. He provided an interactive endodontic program to the Ontario Dental Association from 1983 to 1997 and was awarded the ODA Award of Merit in 1987 for his efforts in the provision of continuing education. In 1994, he was selected for the fellowship in the Pierre Forcher Academy for his contribution to the art and science of dentistry and to the Academy of Dentistry International in 2002. He is the author of over 70 publications in the field of dentistry, and he has done so many publications in the field of endodontics, implantology internationally. He is the global clinical director of dentaltown.com, and his role is to ensure that mobile connectivity of today's digital world creates a new standards in the delivery of dental continuing education. The founder of Roots, and he currently runs the Facebook page Nexus and Dental Divas Global and maintains a private practice in endodontic solutions in Mississauga, Ontario, Canada. Thank you so much, sir, for joining with us. And it's indeed a privilege and honor for all of us who are listening to you. We have people connected all across the globe to listen to your vast experiences. Sir, as you had seen a very long journey, what I feel from 1973, I think I was not even in the mind of my parents that I will going to born. But yes, you have seen the dentistry growing from the grassroots level till the new advances in dentistry. Sir, we would like to know your journey. How was it in the entire field?
Well, first of all, it just means that I'm very old, and you probably weren't born when I was already practicing. I don't practice any longer, and I think the CV is probably out of date, but that's irrelevant. When I got into endodontics, the class prior to mine included Mike Shenamblo and Cliff Ruddle, so it was a very auspicious beginning. John Schoeffel, who invented Endovac, also initiated thermoplastic gutta percha, the gutta gun, as it were, back in probably 81, 82. So what I basically watched over the years was the transition from step back ultimately to nickel titanium, from radiographic terminus and trying to figure out lengths, to apex locators, the microscope, which I took courses with Dr. Carr early on. So he changed the endodontic world. Subsequently, throughout the early 2000s, we started to move to minimally invasive endodontics. We started to incorporate more prosthetics with our understanding of the direction that endodontics needed to go with respect to preservation of coronal tooth structure. Cone beam tomography. And so basically we had a microscope, we had an apex locator, we had cone beam tomography, we had a variety of, I missed my finger. We have a variety of, we have a variety of nickel titanium, austenite, martensite, colors, heat, grinding, stretching. And today there is static, which is fine for implants, but not so fine for endodontic. And then this all sort of, as my career came to an end, dynamic navigation entered into the sort of milieu, because the system that I was aware of, using, learning about, was in a Toronto-based company. And a gentleman named Jason Pardo, who I knew from Consult Pro years ago, he was involved with the company, sales and marketing on a global basis. Took a look at it and I said, this is it. This is where we're going. So that's pretty much the sort of longevity. When you're around for 40 years, you see pretty much everything. You get to know a lot of people. But the fun part of endodontics, from my standpoint, is we finally segued over to understanding soft tissue and hard tissue augmentation, like our implant brothers did. And so endodontics grew up in the last 10 years. Retreatment, surgery, we got sophisticated. We were able to do a lot of things that we couldn't do. And so now this is where we are. Dynamic navigation sort of closes the loop, because now we are digitally oriented in every conceivable way. For the moment, I'm sure augmented reality and AI is going to kick in very shortly. But for now, we've kind of closed the loop, and that's a good thing.
But sir, one of my curiosity is that you did it in nuclear medicine. So how come from a nuclear medicine you went into the field of going into this? I'm really amazed to see that and want to really know about it, how exactly it happened. What was that energy which made you do that?
Well, I was very fortunate. I met Marjorie Kaplan-Jeffcoat, who was the dean at Penn, very well-known young lady. And I had to do a research project because at that time, endo was 2 years. I went to Harvard, so it was 3 years. And you were required to do a master's of medical science degree. So I started chasing around Harvard. I met Marjorie. She was brilliant. And so she was doing indium, gallium, and technetium scans. And I said, well, that's pretty amazing. So she showed me some papers that had been done by an orthopedic surgeon. And he was finding failure of implants, like, hip replacement, knee replacement. He was working on Vietnam vets, and he would pick up strep virinans. So she showed me the paper, and she had what was called a cadmium telluride probe. So we started doing comparison of radiographs with using technesium, indium, and gallium to see if we could pick up occult dental pathology before it manifested. So I think the most amazing thing we did is there was a patient at Sidney Farber, which is the Cancer Institute in Boston, and they couldn't control this guy. He raging infections. And so we said, you know what? Let's take a look at his mouth, which was really ridiculous. And sure enough, he had a massive abscess on an upper first molar. We picked it up with the nuclear medicine device, did the root canal. I think we did the root canal. And everything settled down. So I had thought about staying on and doing it, but Canada beckoned. And the Medical Research Council of Canada wanted no part of an endodontist doing research in nuclear medicine. They kind of laughed and submitted the proposal. Said, okay. So I started clinical work. It was a shame because I honestly think that at that time anyway, there was an indication for it. You're looking at now ultrasound detection. There's a lot of transitional change. And I spoke with Victoria's dad the other day, Marcus, and as he pointed out, endodontists and periodontists, they're crucial. We are the gateway to sepsis in the body. So if we can control sepsis, then as long as comorbidities are under control and you've affected biomodulation, the reality is if we can control dental disease, then the systemic issues could theoretically be brought under control. So even back then, it made sense that if you were able to integrate an evaluation of medical conditions with dental conditions, the odds of helping patients achieve a much more optimal health, somatic health, were greater. But it took a lot of years, but we're getting there. We seem to be on the right road now.
Very nice. I feel so. It's a very incredible journey what you had actually traveled from. As I said earlier, from the days of inception, like how the endodontics was at a grassroots level. And sir, how do you think the new technologies which are coming in, like magnification and the dynamics, it will going to change the world of endodontics? How we are looking at?
Well, it has. When Roots was started, so microscopes were just kicking in. Dr. Carr had done his work. He started developing all kinds of devices, beam splitters and whatnot. They were documenting for the first time. You could look inside a canal, record it, look inside a chamber rather. So magnification and illumination, it's just reality. When I graduated, we didn't have loops. So it was you were eyeballing it, which was kind of weird. But you know, loops, larger magnification, but microscopes pretty much consolidated everything. And you know, now you've got, you know, fancy ones, you can talk to it, it moves. I mean, it's gone crazy. But by the same token, it allows you to document. And the beauty of documentation in any discipline of dentistry is you can look for your mistakes. You can figure out where you went wrong. So in and of itself, microscopes in terms of, you can see things that you could never see. They're improving, the optics are improving, the costs are dropping. I think it's Zumax from China. I don't know if the tariffs have affected it, but the Zumax scope is incredible. It's as good as ProErgo, but it's like half the price. But the beauty of it is the documentation. You can record things and, you know, look back, just like you can with implantology. You know where you made a mistake, and that's a learning experience. So I think, I mean, it's never going to go away. It's not certified. You don't have to have a microscope, according to the AAE, the American Association of Endodontics, which is preposterous. But like everything else, a little bit glacial until they get to the point where they sign off and everything's good. So I think it's, I mean, microscopes are fine for endo, but microscopes are essential in every aspect of dentistry. Perio, not ortho, obviously, but, you know, oral surgery, implantology. I think even those groups will recognize the inherent value of that level of magnification.
Great, sir. So thank you so much, sir, for sharing your journey with us. And it's actually a very vast experience, and very I have less words to express on that the kind of experience you are having. So let's go ahead, sir, and let's take this to the next level. And as you said that the learning is never an ending process. So I think we should start with the today's presentation, which is the need of the hour, I think, and which is the future of the dentistry, both in terms of I believe endodontics, and also in terms of the implantology. So, and that is what we are. So, sir, I kindly request you to that we can go ahead with the presentation.
So you want me to turn on my keynote? Is that what you want me to do? Okay,
yes, sir, please.
There
you
you
can
go.
Just maximize the presentation. Just go on full screen.
Okay, whoops, hang on. Let me stop. Hang on, I went too far. We were playing with Libby.
No worries.
Hang on, everybody's probably getting really busy right now. All right, somewhere along here, and ta-da!
Yes,
okay, we're good to go.
Yes, sir, it's all good to go. Thank you, sir.
Okay, so like, don't feel bad because we couldn't get this to work, but it's working now, so it's all good. So dynamic navigation obviously was being used for implantology. Dynamic navigation, micron trackers had been used for surgical brain surgery. It had been used for ENT. I think I'm not sure if it was spinal or cranial surgery. It just got approval for. But around, I guess 2000 something, 14, something like that, the recognition of the value of dynamic navigation for implant placement, bone surgery, kind of made sense. The levels of accuracy in terms of the difference between freehand and even static, it was enhanced dramatically. So if there's a keyword or a buzzword to walk away from today, it would definitely be real-time feedback. It's the only technology that right now allows you to actually watch what your instrument, your surgical instrument, is doing. We'll talk about PET in a minute, because I'm convinced that if you're going to do any socket shield, partial extraction therapy treatment, if you don't have dynamic navigation, you put things a little bit at risk. Now, that has nothing to do with endo, but it was kind of what fired my intention with respect to all of the considerations for how can I put this, for accuracy, for the ability to watch what you're doing. So, for example, freehand navigation in the minimally invasive era, it's good. You can do it. It's fantastic. It's orifice directed. It's caries directed. everything's changing. You know, in a case like this where there's actually no restoration, it's impressive to see this kind of work done. This was done by a gentleman named Raj Vora, who's a brilliant endodontist in Toronto. And so you can appreciate what freehand can do, but in the hands of somebody who understands the use of a scope and who is really sophisticated. As they've gotten further and further along, in a case like this where the canals are reasonably open, that's fine, but you're not treating teeth at this particular point in time where the canals are this open. You're looking at calcified, sclerotic, metamorphosed canals, and that's where dynamic navigation really kicks in. So they went to static navigation, and the problem here is the same thing as implants. You have to use literally extenders, although just longer burrs, which of course have greater wiggle. And in a case like this, you can appreciate that if you're statically guiding your instrument to do the actual access preparation, chasing a canal, because you can be slightly off even in the manufacturing of the stent, you're still at risk. I don't see these as being an answer for orthograde, but they have potential for surgery. Now, in this particular case, they were removing a file. This was done by Dr. Souza Diaz. And I must make a point, people shared this with me because in Canada and the United States, they just got approval for endo. So anything done off-label put everything at risk. So these were shared by other people who were able to do it because they were not located in North America. Nonetheless, the work is brilliant. For example, in this case, even though he, static navigation found his way, the orientation was great. You can see the file sticking out of the root end here. He's retrieved it. But again, this is cumbersome. And I guess that applies to anything. I think not so bad in implants, but endodontics, if you're doing surgery, is horizontal, not vertical. So if you have to put a stent in for a trephine or something, you're literally pulling the cheek out to an extreme distance. And if you're going to use a trephine for argument's sake, which is what's being shown a lot in the Journal of Endodontics, you still have issues with water and this sort of thing in terms of irrigating the crypt. So that then brought us to dynamic navigation, which basically, as I said before, is free as real-time feedback. So the transition obviously is freehand to static to dynamic. I haven't lectured in a long time. I'm finding this difficult. My tongue is not moving correctly. Anyway, this was the cart that is manufactured by Navident. The beauty of it was that it's portable. It weighs about the size of a vacuum cleaner, maybe a little bit more. Probably needs to go on a diet. But this is basically what it is, and I'll explain the components in just a second. So at the end of the day, the concept is really quite simple. It's like a GPS. It's actually Waze for teeth. Okay, you're triangulating the camera, stereoscopic camera, with optical markers, as you'll see in a second. So it's the same thing as what the satellites are doing with your car and that little nubby thing that's usually on the back above the back window. So there's accuracy here, but with Waze, you can't see the third dimension. You only know where your car is going. You can't see if it's going up and down a hill. You can't see if it's banking. So that's what's required in dentistry. So to me, static navigation was Waze. Whereas what dynamic navigation is, it's sort of Waze on steroids, or Uber Waze, I guess you would look at it. So the concept is fairly simple. You have a passive camera in contrast to cameras that were available that were essentially infrared. The tracker has been around since about 2000, 2002, 3. It's been used obviously in surgery, cranial surgery, as I said, spinal and ENT. I'm not sure of the timelines, but the bottom line is it's been used extensively by surgeons. Like the tracker has been used. I think, who owns it? I think Lexmark is they franchise it out. I don't recall. I don't know much about the medical side, but it's basically the Philips has it. And it was manufactured by the same people, or at least it was developed and then licensed, I guess, by the same people who make Navident. So it uses available light, okay, which is fine, but there is a light in the camera, obviously, that you have to be careful with this light and an operatory light because you can bleach out the markers, which you're seeing down here, the X points. All right, so you triangulate it with the X points on, in this case, it's the drill tag, and in this case, it's the jaw tag, which I'll explain in a moment. So these are X points, I guess. I don't know, it's better to call them optical markers, I think. And then you're watching the computer, because this is the one thing that throws endodontists, is you really are not looking through the scope when you're actually starting to do this. Once you've done your access and you've followed the path, then you switch back to the scope. So it throws endodontists in particular, not as much as it would with implantologists. But for endodontists who are used to looking through oculars, it's an issue for now. So the difference here, this was Dr. Bobby Nadeau who's doing this. As you can appreciate, there's an Abident, which may be showing behind me, I don't know. Jaw tracker is attached, and I'm going to explain all this in a second. He's basically watching the drill on the screen in the various frames. And so he's, if you can see, there's a scope, but he's overlooking at the monitor. So he very cleverly changed this. So the work that's being done now is to modify the monitor. So you bring it from a distance to an iPhone that's attached by a bracket, and then connect it, obviously, to the software. So the algorithms show up on the iPhone. With the new iPhones, especially the ones that are coming out, the resolution on the screens is amazing. The other option was to put the actual target, as you'll see in a minute, into the ocular, or to use augmented reality, all of which are possible. The technology's there. It's a question now, obviously, of demand and getting involved in software development. But I think it's also around the corner, and augmented reality will be used in a lot of things for diagnosis in dentistry. So what this is effective, to me, what it's more effective is, I don't think you need to use it for every access, but increasingly, we're not endodontists, you're not seeing cases that are clean. You're not doing wide open canals. You're doing highly calcified canals, trauma where there's been sclerotic metamorphosis and moving the canal further and further to the apex. And you're using it for surgery. I do not believe at this point in time that anybody who chooses to do surgery, the incorporation of dynamic navigation, as you'll see in a minute when the videos play, there's no way that you can be as accurate with a Lindemann burr, with a Trefine, with a Piezotome, achieving that 0 to 10 degree slice at the apex as you can be using dynamic. And where it's really interesting is auto transplantation. So it's so much more sophisticated because you can get real-time feedback as you walk around the tooth and adjust the socket to replace it. I mean, currently they're using 3D, replication. They're using printing so that you can reproduce the size of the tooth and modify the socket. But it's interesting. I think people will see more and more that, with changing societal, economic, socioeconomic changes, auto transplantation is sort of kicking back in the high gear, and I think dynamic navigation is going to be a big part of that paradigm shift. So to make it simple, when they did implants, the sort of marketing trend was scan, plan, trace, place. The only problem was it was done with fiducials. And fiducials are little, they're aluminum markers that go into a stent. And that way you can reproduce the position of the stent from, in any case, CBCT becomes attached to the optical marker. The problem with fiducials is you have to make the stent. So if you have to make the stent, then there's always the risk of manufacturing problems, distortion, whatever. Whoever makes it, I don't know, they could have had a bad day and they were a little bit rushed. Plus it was an extra appointment because if you had your own CBCT, it wasn't an extra appointment. It takes 20 or 30 minutes to make it. You had the patient take the CBCT. You had to do it at the same time and then work through. So the advantage of going to the EndoFlow and obviously the new flow for implants was you don't need this. They're using what's called trace registration. And so trace registration knocked out stents, knocked out the time to manufacture stents, and essentially reduced the actual time of mapping the jaw onto the computer monitor probably down to 3 to 5 minutes. So it's not, the hard part is the initial learning curve, which if you practice is not really all that difficult. And I'll explain why I think endodontists are probably more adept and better oriented to do dynamic navigation. But as you'll see in a moment, you can always check your accuracy, which is very difficult to do with a stent, very difficult to do with static navigation and endosurgery or orthograde endodontics. So you will see all this in just a minute, but basically this technology, the level of accuracy is unimpeachable, and you'll see some studies done at the end, certainly demonstrated in implantology. But to make it simple, what you're doing by virtue of using trace registration is you are mapping the jaw. You take the alveolus, the teeth, and you literally are putting it directly into the monitor. That's why you're watching the monitor. And as I pointed out before, monitors will get smaller. The resolution at some point will get up to 8K. It'll end up being inside the actual oculars. It's all going to change. And technology is always going miniaturized. So in the absence of a fiducial, you take the scan. Okay, it can be taken 6 months before as long as no teeth have been lost. It doesn't matter when you take the scan, in contrast to using static. So in terms of the use of CBCT for identification of calcified canals and such, they're working on noise reduction, they're heightening acquisition speed, resolution is improving, and there's going to be, I think personally, an introduction of minimal artifact reduction algorithms to take things into CBCTs, chairside, when you're actually doing, in this case, dynamic navigation and other forms. Because what happens is when the company does the CBCT, the MAR is already in the system. So what you're looking at on their monitors is pristine. It looks like it was painted. But that isn't what you do when you bring it into the actual dynamic navigation system. Obviously still highly visible, not an issue, but it's fairly straightforward. As things are changing, all the companies are going to compete. CBCT competition is who's got less noise, who's faster, who's this. So it's an evolutionary process that's going to occur regardless. So what's required is a jaw tracker. You have to know where your patient is at all times. So without trying to sound funny, as long as the camera can see the jaw tracker, the patient could be hanging from the ceiling, because it doesn't know who the patient is, where the patient is, really doesn't matter. All it knows is the jaw tracker. So the initial attachment was done with composite, not an issue, but I guess there are people that would find it annoying. But the new ones that have come out are using a peak, looks like a staple. And so you put it literally looks like a staple. It's 2 or 3 teeth long, and you use blue mousse. Now, I don't know what blue mousse is. I thought it was funny because you can attach the jaw tracker and have it for dessert. So I thought that was pretty cool. And there's also a bone, Tracer B is Tracker B rather, it's a bone tracker. You put little ortho screws in, attach it to the bone if you're doing an edentulous case. It's all very intriguing and all very doable. So in terms of dynamic navigation in the minimally invasive era, I think it's going to heighten the minimally invasive era. So what you do basically, in order to map it, you don't have to do this in the mouth. You can do this at home when you're having a beer watching The Simpsons or something. You can do the landmarks, you establish them on fairly easy to identify points on the teeth. 3 to 6 of them. It's very straightforward, quite simple. And so the machine is actually telling you where it is that these should be identified. If you're in the wrong place, it actually says you're in the wrong place. Like, the interesting part of the software is it actually talks to you all the time, not verbally, but in terms of text. So you identify your landmarks, and you then have to go in and do trace registration in the mouth. So what you're looking at here is a tracer tag, and I'll show you the barcode in a bit, and a tracer tool. So you've got the optical markers are attached to this tracer tool, and the new ones are going to look like the one in, this is Doron Deckel's hand. He's the guy who started this whole thing. He's the CEO. And the computer engineering genius behind this whole thing. Now that's what the new ones are going to look like, and that's probably a prototype. It's probably going to get smaller and easier, and they're starting to get ready to do it now. So you have to calibrate this. So you have a barcode that tells you what the manufacturing process was to get your tag. So you know the exact dimensions. I have to get something from Indention. So you can know the exact dimensions, and then you can calibrate the actual tool. So the machine actually knows when you look at it, when you look at the optical markers, the X points, whatever, it's completely accurate. You know the distance between the tag and the tracer tool tip. And you put it into this little dimple on the calibrator, and I'll explain this in a minute because it's actually kind of funky. They haven't figured out how to do Trefines, or they know how to do Trefines. They just haven't put it on the calibrator, but you can kind of jury rig it, MacGyver it, and I'll show you that in just a second. So this is basically what's going on. Okay, you've got the landmarks, and then you start to trace them. Okay, quite simple, quite basic. There's a bit of a learning curve with tracing them, but there's also the capacity within the system to allow yourself to do little testing. So essentially what happens is you're doing a cloud of points on the facial, the occlusal, and the lingual. So it's almost like you're painting the tooth with the tracer tool. The machine is recognizing all the dots, or in this case, I never understood. Nobody ever explained it to me properly. It's either 100 points or you reach 100% of the surface area. I'm sure somebody will explain it to me after this is over. But it's kind of funky, actually, because every time you touch the tooth, you hear boop, 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 boop. And that's telling you in the points, and it kind of accelerates until you've got what you want. And then you get a little check mark, as you can see right here, right? And so when you've done all of the trace registration and all the landmarks, Daron thought it would be really cool. The system goes, ta-da! So you actually get rewarded in terms of what you're hearing. So this was what I found was the easiest thing to do to learn how to trace register. There's a trace visualization. It actually shows you what you did when you were touching the tooth. Shows you whether you were on top of the landmark, and then the green dots tell you your accuracy, the red dots tell you you blew it. But obviously, the cloud is accurate. As long as the red dots are to a minimum, your trace registration has been accurate. But it goes one step further. You can do an accuracy check. So you take your tool, and the machine shifts into this. And as you can see here, the tracer tool obviously was accurate because you're looking at 0.0 millimeters. Now, to be perfectly honest, that is, you'd have to be like nearer my God to thee to do this, but it's kind of like 0.1 plus, 0.1 minus, 0.2 plus, and you know that you're accurate. So you know that your trace registration was dead on, and the jaw and the teeth that have been mapped onto the monitor are in perfect position. So now you go into the handpiece, okay? You know that everything's there, your jaw's in place, everything is completely, you've taken a perfect mapping of the jaw, the teeth, and stuck it in the monitor. So now you have to calibrate, using the drill tag, your handpiece. Now the beauty of this system, in contrast to others, is that it uses a high speed. So you can't do endo with a slow speed, because that would take a week and a half to do an access. But you know, it's handpiece agnostic. So you can take anything you want, any handpiece that you want to use, from gray market to Tavo, and you just do the following. You calibrate it. So once again, we've got the tag, we've got the drill axis, and you calibrate it. So the machine actually watches you do this, and it actually does the calibration. You'll see it be counted on the machine. And then obviously you're going to do this kind of stuff. You're going to put a drill, and then you're going to calibrate with the drill. So you know exactly where the optical marker point is, the X point, as it relates to the drill tip. And the lesson to be learned here is never take a quality product shot when you've got a burn burr in there. So that's why it's black. So not a smart move. However, you can also do piezotomes. And as I was saying before, this is how you do a calibration piezotome. You see these little rings around here? You can kind of MacGyver a trephine. Obviously, it's not recommended, but so it's an off-label concept. But as you'll see shortly, you can do it. It's quite straightforward. So this is what we're looking at. You have frames. This would normally be a 3D rendering. This is the pan. So when it was originally designed for implants, if the implants were too close, the second implant to the primary implant would go red, and it would basically say, you blew it. However, in the case of endo, originally, before they moved into what's called 2.21, which is the current software version, when you put one canal against the other, basically it would go red, but irrelevant. So here you can see, for example, the access into this molar is being done. Now, this was the true jaw for demonstration purposes, but also as close as you'll come. This is a training situation, but as close as you'll come to a natural situation. So you can see once you've lined up the drill axis over the drill tip, you can see here, for example, this is the horizontal offset. So you're 0.1 millimeters away from true in terms of the long axis. Here you're 0.1 degrees off the true, okay, and it measures it. And you're down, it tells you what it is, because obviously the machine has that sophistication. And then you're 9.6 millimeters from the base of where it was that you did your planing. So appreciate that in upper molars, you've got MB2s, DB2s, and all kinds of weird stuff. In lower molars, you've got 5 canals, which increasingly is becoming the norm in terms of recognition. Lower bicuspids have, you know, optimally 2 canals in most likelihood, and 3 and 4, which according to Facebook is becoming the norm. And obviously you've got lower incisors and older individuals like me when the canals are calcified, tough to find, 50% or 2. Increasingly difficult, but minimally invasive is required. We can't just blow open a lower incisor. It just, that's it. You know, that's the end of that tooth. Similarly with cases, large class 5s where canals regress. So it has tremendous applicability for orthograde, but it's got supreme applicability for surgery, as we'll see in a moment. So here's the same case, but you're slightly off. The degree is 0.5. Now, in this case, it was done with acrylic. All right, so acrylic softens. It's not so easy to play with an acrylic tooth. It's a learning, you know, it's basically where you do your learning curves. But it's easy to be off. So that would be a 50 file. You know, you don't want to be off by a 50 file, but it increasingly gets lower and lower in natural teeth because you've got the resistance of tooth structure, dentin and such. This is acrylic. It heats up. You know, it is what it is. You're obviously going to have some deviation. But 0.0 millimeters, that's not the apex. That's the depth of the plan. And then obviously you pick it up from there and do your work. Someday they'll probably put an apex locator on this and simplify things even further. So this case was done by Bobby. As you can see, Ninja access, you know, perfect, all done, very real, very straightforward in terms of what you're doing. I don't know that I'm a big believer in Ninja access because of the residual material, but you can literally do anything. And that would basically be the way all of these dynamic navigation accesses would look. There's just no reason to open them up. So somebody would say, well, I can do this with my scope, but no, you can't, because as an endodontist, probably 80% of what you see is retreatment or going through crowns. You go through a crown, you've lost your landmarks. You go through retreatment, so there's either decay or a fiber post. So there's no way you can get a fiber post out as effectively as you can with dynamic navigation. So I understand everybody say, well, I can always find my stuff with my microscope, but the answer is you can find it better using dynamic navigation. So here's what the target looks like. It tells you where the front, the back, and the side is. Again, as I mentioned, it shows you horizontal distance off the path, the angle off. Now, obviously, this was goofing around because 7.9 is not acceptable. I don't know why they shot this. They should have said 0, 0, 0. Well, whatever. Vertical distance, you're down 7.2 millimeters towards the termination of your plan. And this is your drill axis, drill tip. And the reason I said endodontists probably have an easier time of it is we're used to setting up the long axis. You know, we want that drill to go in along the long axis of the canal. So positioning the axis over the tip as an endodontist is easier, I think, in contrast to an implantologist who, you know, drilling out an osteotomy, they don't worry so much about everything they have to move in place because they've got a ton of bone to work with. With teeth, it's a whole different story. So as an endodontist, I think you're far more equipped to handle this. So this is a case that was done by Armando Hernandez. I took the music off simply because I had to talk over it. So you establish the occlusal plane, you do a jaw curve so you can relate it back to the panoramic, which is where you start placing your implants and such. You can see he's starting to place his implant, which in this case, he shrunk down to 1.0 millimeters, the average size of a burr, although I think you can go smaller today. He did his plan. These are his landmarks. He's calibrated his tip, now the drill tip, and he's going to work. And as you can see, because he's an endodontist, look how easy it is for him to get right over the tip. So things are moving down in this lower molar, and he's going to get closer and closer and closer and closer. Obviously, you have to develop a certain facility. This was the first time he ever did it. So that's what you're looking at. You know, pretty impressive in the grand scheme of things, especially in the type of cases that we're doing today. They're all highly calcified. So now we move into piezotome usage. The new one, the 2.2.1, allows you to actually plan the piezotome window or the bone lid. And it will obviously do the same thing with your Trifine. Once Trifine, the calibrator is, it's not that big a deal to get the calibrator. It just hasn't come to that point. I was talking about PET. Isaac Cowell, who is a user, is working on a Trifine that's specific for pet. And the reason for it is very simple. Right now, they split the roots, they use diamonds, they try and chase down to the apex, but they can't see where the burr's going. But with the Trifine and dynamic navigation with PET, it's a slam dunk because you can actually watch the Trifine going, and obviously you leave a very large segment of the root for the socket shield. So I think it's a more predictable way of doing that procedure. So to walk you through quickly before the video to give it context. So the jaw curve was drawn. You can see the Trifine working. You can see the bone window. You can see the root ends, and you can see it being put back. The reason it was done in this case is obvious. You can't take the post out. I mean, you could try and take it out if you wanted to, but you probably do all kinds of damage, especially because the cervix is so small. You can't get the post out here either, and you can see where the post is in terms of trying to deal with the pathology. Well, with dynamic navigation, the resection was clean. You got close without actually being at the level of the post, which is impossible to seal. So just to blow it up and give you a sense, you know where the nerve, you know where the mental nerve is. You can follow the arch. You can see the cut when you're working, exactly where it is. That's real-time feedback. There's the jaw tracker position. There's the window. There's the section. And there's the result. So let's take you for a walk through the video. Okay. So I added the Eagles. It's my favorite group. So you see the optical. You can see the jaw tracker. Okay, they're doing the trace registration at the moment, and now they're going to work field tag and Piezotome. So you can actually watch it, like I said, going through in real time. And with the new software, I don't think it's beta anymore because it's 2.2.1. You can follow your plan for the Piezotome. So you're in a position where no matter where the Piezotome is going, you can use sections perfectly along, in this case, the lingual, and imagine doing the same thing with regard to mesobuccal roots. And from my perspective, transanthal palatal resections are quite straightforward. So just to show the case with the bone lid, this is Dr. Villa, who's probably the consummate surgeon in the world. She's from Colombia, Medellin, and Paula is brilliant. Okay, bone lid is taken out, put into saline, and then obviously things are cleaned up. She resected the root tip at this point in time, so I think that's what she's pulling out. There you go, little puppy, and it's coming out. And there we are. And then she's going to do her retroprep. But that's as clean as you clean could possibly be without gouging. You know, it's not a round burr or a Lindemann, you don't know where you are. This is perfect. You could actually, if you wanted to, you could probably calibrate the tip with an ultrasonic in really bizarre cases. Especially in palatal roots, that would probably be really intriguing. So she's cleaning everything up. She's putting in her PC sealer or putty, whatever she uses. And speaking of which, Isaac, Powell, we need a much better BC sealer putty. BC putty, well, BC sealer goes in first. Placement tool, so tell a seed to get it together. She's using Paula tape here to stabilize it. I mean, theoretically, you could put a membrane of tacks on here, but really, I don't know, it's a little different because what she's done is the apex is slightly wider than the coronal aspect, and the walls are cut convergent, so it literally fits back like a cork into a wine bottle. It's a bit of movement, obviously, but it can be stabilized. And she's so good. Look at her. Look at this. You can put a membrane over it, resorbable membrane if you want, but that's the case. And as you will see, here is the result momentarily. And let this go because I really like Hotel California. So there we are. Now this one, which is also the Eagles, this is Glenn Fry, just in case anybody was wondering. There was a file that went out. No, you know, there are people who would try and take that out, and that's all cool. But, you know, removing the file is still not minimally invasive. So here she is working through, cutting the root end. Yeah, she's cutting through the root. There we go. And that's real-time feedback. You know exactly where you are. I mean, try and do that with anything else. It's not possible. This is why it's so amazing. Doing the mesial root now. She is so good, Paul. She's amazing. Just such a talent. You know where the IAN is. As I say, now you can plan it out. You just follow the path, which is actually pretty cool. So this is freehand surgery in a sense, but by the same token, you can see exactly where she is, and you can see it in coronal sagittal and axial disease. So out it comes. There are those who dispute bone lids, but I think that's completely erroneous. I mean, it's like the ultimate autogenous bone. And then obviously in cases like this, you can use a scraper. I think from a standpoint of preventing granulation tissue from regrowing and not doing the bone lid and getting it in for the tissue in the crypt heal, I think it's an amazing way to do things. So there it is, files out, perfect resection of the root end, cut across horizontally, beautiful. Beautiful bit of work. And then obviously the ultrasonic, the rectal preparation, excuse me, and then the retro seal. You can just appreciate how, you can give yourself enough access to the retro prep. If you have to, you do a keyhole. And there you go. You take a peek with the methylene blue. Excuse me. And voila. Clean it up. Bone scraper. That's so cool. What a great edge. Okay, everything's cleaned up. And put the bone lid back in a moment. Stabilize it. And Bob's your uncle. There we go. And the final x-ray will show. There we go. On the right. Sort of cut off a bit. But beautifully done. And now this last one, I don't know if the people from Navian are going to be happy with this, but I don't know. Whatever. Okay, so this is a Trifine, and this is really cool because it's basically putting the cork back in the wine bottle. A couple of things here. Black triangles might be interesting to have done a connective tissue graft, normally reposition graft, but we're endodontists. We're not supposed to do that right now. There's the Trifine, again, dynamic navigation to pop out the cork. With the Trifine, you could actually do a biopsy. You want to take up the tissue, it comes out with it, and you can actually do the resection, which is kind of amazing. And there we are. Retro preparation by Dr. Vida. So good. It's amazing. Love watching it. Isaac, there's the instrument that we need. And voila. And cork it back. And there you go. Got to keep those natural teeth because those platforms cause bone loss. Okay, so we're coming to the end. So this was a study done with Dr. Stefanelli. I said that right this time, I think. Luca, did I get it right? Stefanelli. And so you can see the difference between, in this case, Navident and XNav, which I thought was pretty amazing in terms of the entry with respect to millimeter differential from the plan, the apex, which is, again, pretty dead on, and the angulation, which is obviously very desirable. Now, for example, if you were using a Densibur, these would be very cool, especially if you're dealing with the sinus elevation, sinus lift. So Unguided, which was done by Dr. Block, who is, I guess, he must be the XNav KOL. You can see the difference in terms of when you have a 95% confidence margin. Navident kind of rules the day. These are the articles that have been published to date. Mine were kind of fluff. The others are peer-reviewed. So Dr. Gambarini is the fellow who at Sapienza is doing all this amazing work. I mean, Gianluca is brilliant. They've got, I think, 5 or whatever studies coming out currently. And Dr. Jane, who's at the Commonwealth, I think at Commonwealth University of Virginia, or I don't know, probably mixed up the acronym. But Samir's a young guy. He's going to be doing this forever. And this is sort of the trend. You'll start to see it. There are people at Nova who are looking at doing this for palatal root surgery, Dr. Silberman, and there are others. It's a trend in endo. I don't think it's a trend actually. It's a reality in endo, and that's where we're going to end up. So thank you for listening. Boy, it's been a long time since I did one of these. And we're done, young lad. So what do I do here? I get out of this. There I am. And where was my friend? And we're back. We're back.
Yes.
Let me turn up the volume.
Thank you so much.
That's so cool. Thank you for letting me do that.
It was actually a very amazing session, sir, what you had, and very enlightening for us, and especially knowing about the new technologies of the dynamic navigation. I think that will be the future of, I think, dentistry. I will take it as at large, rather than specific to endodontology or probably to implants. So I have some few questions, sir, for you to, if you can. What is the difference between a static navigation and a dynamic navigation? What is the difference between the accuracy if we take it at large?
There's no way static could ever be as accurate. Number one, you have to manufacture it. Number two, because you have to go through either a small window or a trephine tube. First of all, with the trephine tube, I don't believe you can get the irrigation down there, which is why Dr. Towell, and I don't know if I'm involved, but they're looking at a better trephine, which will be used for microsurgery as well. The static is just a tube sticking out or a window, but it's unless you have a Stratus 3D printer for $100,000. If you buy some one of these things from Amazon or from Blue Sky Bio, they're $5,000. They glue up after the second stent. You have to maintain them like crazy. Plus, there's no way that the accuracy of that acrylic stent, the static stent, could ever be as close to what dynamic navigation is. And then the key is the feedback. If you can't see where the instrument is in terms of an axial position, so what is static navigation giving you? An access point, but it doesn't allow you to go to depth with any level of accuracy, other than what you plan on the CBCT and the hash marks on whatever, be it the trephine, whatever on the burr. Whereas dynamic navigation gives you that visual perception, the real-time feedback makes all the difference in the world.
So in cases of the multi-rooted teeth, which one is better to go for? The static navigation or the dynamic for the multi-rooted teeth?
Multi-rooted teeth, same thing, same consideration. If you look at, I think the best way to look at it is every mesial buccal root is analogous to a lower incisor. Finding an MB2 is never easy. Depends on where it's located. Yeah. What's Fertucci got? 9 different configurations. So I think the key is that because you can identify where the canal is, even if there's a crown in place, the new software, there was a bit of an issue with crown teeth. You had to it was difficult, but not anymore. There's not an issue with zirconium or PFMs. They can identify and trace register on it. So if you can do that, and you're dealing with crowns or retreatment, there's no way static could ever possibly help you do that. Dynamic, on the other hand, doesn't care where the crown is, because it's just seeing where through the axial slices, where the actual canal shows up. And that's what you're planning. So it doesn't matter. You're not going through a crown, lost all your landmarks, the dentin is discolored, it's a mess, there's recurrent decay. This machine, the algorithms in dynamic navigation just say, there's the canal, doesn't care if there's decay, doesn't care if there's a crown, and you go for it.
So in terms of the stents, we to go for a stereo for the polyvinyl siloxane one can also work for us. If you go for the stents for the navigation, the stereolithic stents are there and also for the navigation.
That's the problem. You have to make the stent, and there's always a processing error. Whereas with dynamic, you can lock that tracker onto the teeth. I mean, the one that they've come up with now is Peak, and it's got this blue mousse, which I've never taken an impression with it, but it's rigid and stable. So they use composite, but now that they've gone to this other material, you can't possibly make a stent that's as stable as that clip or whatever that's holding the jaw tracker. It's not possible. Can't be done.
So for the CBCTs, as you were saying, if you have to go for the CBCT, then we need to actually have those DICOM files to be attached to it, and how exactly we can do it with that.
The system is designed just to import the DICOM files. It's again child's play. The person who wrote this, his name is I just forgot his name. Anyway, the software algorithms are written such a way as you just import the DICOM from a disk, which nobody uses anymore, perhaps. You can do it through a network, and you can do it through a flash drive. DICOM files come in, machine reads it, you introduce it into the database of the system, off you go.
Great. And sir, if we take it as magnification along with navigation, the DO, what's your take on that?
Well, I mean, realistically, if you can find a calcified canal or you can get your way in through a root resection, then the microscope's easy. It completes everything as you can see, as you can see Dr. Villa did.
Yes.
It's applicable. I mean, if it gets you to a calcified canal, the rest of it is a microscope. Microscope allows you the obvious advantages of looking down a canal with illumination. It has issues. For example, if you had a separated instrument in a canal,
yes.
I would rather do dynamic navigation to get it because I'm dead on. Whereas instead of kind of drilling out to try and find my way around, even if you had Tarocchi's kit, you still have to get to it, right? You have to get to it. And for argument's sake, as I said before, you can't get a fiber post out with anything as quickly as you can with this system because you can see it axially. Can't do that very easily if there's no axial slice to monitor. So in terms of the answer, it's integrated into the scope, and as I pointed out, either augmented reality or you'd hook up a monitor. For right now, an iPhone's great. I mean, you take a picture with the 11, it's as good as a DSLR.
So I was just, when I was reading through this one, and I came to something like a MATLAB software, what is it, that one? So how it going to change the entire perspective? The MATLAB software, something is there?
I'm sorry, say that again. I'm not following.
So the MATLAB software for navigation. MATLAB.
And you said, I'm
There's
sorry.
A new software. The MATLAB, sir. MATLAB. MATLAB software.
I honestly don't know. Doesn't ring a bell. I apologize. I'm not clear. I'd have to look it up, my friend.
So thank you so much, sir. Actually, it was I will say it is like a navigation, as you say, it's a new pilot. I think it's a new pilot which will take us to the, new generation in endodontics and also in implantology. And especially in the field of endodontics, if we talk about, I think if we conclude it in a form, then I think it will be beneficial for us in both in surgical and also in non-surgical endodontics. I think from the access opening and going up to the root canal preparation and also for the retrieval of the broken instrument. I think that's the best way.
If I can just add, I mean, everybody's doing everything today. So they're doing endodontics, they're doing implantology. So it's invaluable to both. So, there's a duality to the protocol. So to me, it just makes sense. If you're increasingly going minimally invasive, which everybody is, especially in like endo restoration, you want to preserve everything you possibly can. So in a calcified tooth, you don't have to start looking at posts. You're dead on, which is really, from my perspective, what makes all the difference.
So I think what I believe, like with your enlightening, like so much of deeper insights of dynamic navigation, I think that will be going to change the entire world, what we have been thinking nowadays. That how, especially in terms of, as you have shown the cases of the microsurgery as well. So I think it will going to entirely help us as I think to look into the newer dimensions of endodontics and take it to the next level of excellence. So I will.
Hey, thank you.
Thank you so much.
Fun, Prashant. I enjoyed this. It was a treat. I mean, you're in Delhi, I'm in Toronto, so this is very cool.
Yes, thank you. And before I answer, thank you so much for doing this webinar with us on this global summit, and from the entire team of the global summit. And me as a chairman of the International Cooperation Committee, we are very humbled and very grateful to you and to all our colleagues and friends around the globe who have actually joined us on this webinar. We are so thankful to all of you. And thank you once again, sir, for your deeper insight and the greater knowledge sharing with us. And I hope with your knowledge and with your vast experience, we will able to reach to the greater heights in the field of endodontics and implantology as well. Thank you so much, sir, and have a great day.
Say thank you to Keanu, because this whole initiative, peer-to-peer and everything he's done, it's remarkable. So,
yeah, so he's, yeah. Thank you so much, sir. Thank you so much.
Appreciate it.
Have a great day. Thank you.
You, my friend.
Thank you. Thank you.